Hello, welcome to today's presentation, Understanding Peripheral Vascular Disease, presented by Dr. Rakesh Safaya, vascular surgeon with Washington Health Medical Group. Dr. Safaya is board certified in vascular surgery and brings nearly 3 decades of experience to his practice. Driven by a passion for helping others, Dr. Safaya's philosophy of care is centered on compassion and patient understanding. He meticulously explains diagnosis and surgical options, ensuring each patient feels informed and empowered. When not helping patients, Dr. Safaya enjoys traveling the world and exploring its diverse cultures. He also maintains an active lifestyle through hiking and swimming. Please welcome Dr. Safaya.
Hi, my name is Dr. Safaya. I'm a vascular surgeon with the Washington Health Medical Group, and I'm here today to talk about peripheral arterial disease in the United States. Peripheral arterial disease is a major cardiovascular disease. It ranks as the third leading cause of death from atherosclerotic disease in the United States. What is peripheral arterial disease, or PAD? It is narrowing of the arteries, which happens because there is a plaque buildup in the arteries of the limbs, and most commonly we'll be talking about the lower extremities because this predominantly affects the lower extremities. It narrows the arteries and blocks the blood flow through those arteries, which supply the muscles and the parts of the body beyond the narrowing. So what does the reduced circulation do? It slows the blood flow to the arms or the legs, and the tissues receive less oxygen and nutrients. And what does that do? That makes us experience pain when we are walking, we are running, or we are stressing ourselves, with normal activities. Even that can cause it because there is narrowing of the arteries and the blood flow to that part of the body is affected. And this is as serious as the risk of a heart attack, where the arteries of the heart are affected, or even where a stroke happens because the arteries to the neck or to the brain get affected because there is narrowing or plaque buildup in those arteries as well. Prevalence in the United States. Peripheral arterial disease, or PAD, affects a significant portion of the adult population in the United States. It's estimated that over 8.5 million Americans aged more than 40 years are presently living with peripheral arterial disease and are unaware of it. As the age increases, say 50 years or more, there is higher incidence of prevalence of PAD, and predominantly it affects males more than females because possibly the males want to walk more, they are more active with the females in comparison to the females, and the females just brush it aside, say it's just I've grown old, it's just things which are happening, I'm not so much active. But if they are more active, they can also feel the same symptoms. Despite its widespread occurrence and serious implications, PAD remains undiagnosed, underdiagnosed, and undertreated in many communities across the country. The risk factors for the disease. At the top of the pyramid, the most predominant factor is smoking. And smoking we have been doing since younger years, teen years, 20s. We are invincible, nothing can affect us, so we don't care. But eventually it catches up with us and it starts showing its effect in the middle years, say around late 30s, 40s, or into the 50s. Next is, as we age, as we mentioned previously, that there's a plaque buildup, deposition of cholesterol, narrowing of the arteries. So all this contributes to PAD. And on top of that, there are other comorbid conditions like diabetes, high blood pressure, high cholesterol. All these together lead to PAD. Demographics and gender disparities. Males, as we spoke, have more overall burden of peripheral arterial disease. They tend to develop symptoms earlier in life. Female, there is a treatment gap as well. because as we mentioned that it has been observed nationally that women receive guideline directed therapy less often. This creates a disparity in care and outcomes. And the impact of age. We are a growing population. The lifespan has significantly increased, and as we mentioned that as we grow older beyond 50s, the symptoms of PAD start appearing, and in addition to presence of diabetes, high blood pressure and high cholesterol. And the incidence of PAD is even more than 20% in patients more than 70 years of age. Diagnosis, treatment and public health gaps. This is an underdiagnosed condition. Many PAD cases remain undetected, so screening is important and overall screening rates are low. Undertreatment. High rates of non-treatment persist. Women face greater treatment gaps. Public health needs. Expanded screening programs are essential. Smoking cessation is at the top of the list, and efforts must be made at all levels: school, colleges, places of work, and even at home. The bad effects, the side effects, the problems which smoking causes. Luckily, the awareness amongst the younger generation is now increasing regarding smoking, and hopefully less and less people are smokers now. Next is the targeted interventions. So programs tailored to high risk groups can improve the outcomes. This is a technician performing an ultrasound on a patient. And what is ultrasound? So we do a non-invasive test wherein we look at the blood vessels in our body. And this is how it is tested. The peripheral arterial disease is tested by checking ankle brachial index. We abbreviate it by calling it ABI, ankle brachial index. So we check the blood pressure. As you see in this picture, there's a blood pressure cuff in the arm on either side and a blood pressure cuff above the ankles in the lower extremities. So we check the signal, the blood pressure, when the pulse starts appearing after we inflate the cuff and then deflate it. So that is the pressure we check, and it should be 1 or more between the ankles and the brachial and the arms, ABI, more than 1. And if it is less than 0.9, so we start having the effects of peripheral arterial disease. These are some ultrasound images as we check the Doppler signals, like we saw the first picture where the technician was doing the ultrasound. So these are the waves which we see. It tells us about how normal is the blood vessel and what is the degree of severity of the disease, in addition to the color flow in these vessels, as you see in the pictures above. So the images we are seeing on the screen, on the left side we have MRA in black and white, and on the right side we have MRA which is in color. So we have similar scans which are done with a CT scan giving an IV contrast, and that's called as a CT angiogram. So where we see the whole roadmap of blood vessels within the abdomen, the extremities, and it tells us exactly where is the narrowing and what are the ways of fixing it. So here we see on the left side, this is again an MR, magnetic resonance angiogram, where we give contrast and check it without putting in a needle into the body, which is invasive. This is sort of non-invasive test. And on the right side we see a conventional angiogram where we see narrowing at the top in the arteries which go to the left leg. So there we identify the narrowing in the arteries and then ways of fixing it. That's called as the angiogram, angioplasty and stenting, like we do for the heart. So what are the treatment options? Number one is, most important, is lifestyle modification. So we adopt a exercise program where we have a healthy daily exercise routine. Like we don't have to do a marathon. We just go around our neighborhood park, walk for half an hour, 45 minutes, and do that at least 3 times a week. And number 2 is, which was at the tip of the pyramid, that is smoking. So smoking cessation, it's not easy, but there is help available. If a person has smoked for 20 years, 30 years, doesn't mean that he cannot or she cannot stop smoking. So they can see their primary care physician, get some help. There is patches, there are gums, there is medication which takes that urge to control that addiction from nicotine, and gradually we are successful in getting rid of our smoking habit. Then next is the dietary changes. Less cholesterol in our diet, less meat products, more green leafy things to eat, and maintain a healthy portions. Next is medication therapy. So there are, if we have done our lifestyle modifications, and now we have to add medications to it. So there are medications in the form of antiplatelet medications, like commonly we have a baby aspirin, and there is other medications like clopidogrel, like we commonly name it as Plavix, or there are other products like anti-cholesterol medications like statins. Important is also the medications which are needed for blood pressure control, and on top of that also management of diabetes. So control of HbA1c less than 7, which will prevent the complications, long-term complications, or delay the long-term complications of diabetes. Despite lifestyle modifications, medication treatment, we can still get pain, and we say, hey doc, I need to do something about it. So that's where minimally invasive interventions come in. So we do an angiogram, wherein we introduce a needle into the artery around the groin and take pictures. That's called angiogram. And then at that time only, we identify the narrowing and open that narrowing with a balloon, wherein that's called as angioplasty, balloon angioplasty, and follow it up with or without. We can just do an angioplasty, or we do stenting, wherein we keep that part opened. So this is a non-invasive procedure. It is a same-day procedure, and we are pretty good at it now. Last 20 years, the results are very good. So then, if still, despite all the above, including angioplasties, and like we do angioplasty for the heart, sometimes those can get blocked again, especially if we continue to smoke, or we are not taking care of our diabetes. So we may need a bypass. So we have to reroute blood around that blockage and using a bypass. So wherein we use a vein, our own vein, or there are artificial veins available too. So we do a bypass wherein we restore blood flow to beyond the blockage, and that way we are able to get blood flow into those parts of the body. Now, despite angioplasty, despite bypasses, we still have to do regular follow-up in order to identify any problems with those procedures or complications of those procedures or further narrowings, and then those can be addressed with another angiogram or repeat angioplasty. So this is a picture schematic wherein we showing a needle getting into the artery on the first picture, and then put a wire across the blockage, and you see that yellow thing, that is the plaque inside, which has been building up for years, and that leads to narrowing in the artery. So we open it up with the balloon, as you see it on the right. This is a magnified picture wherein we have a stent which is mounted on a balloon, and then we place a stent into that part of the artery where we opened with a balloon. So that is angioplasty with balloon angioplasty with a stent. So then what are the next steps in PAD management? So the most important is awareness of this condition, PAD. So we have to identify who is at risk, and we also have to educate the healthcare providers, because the awareness of PAD is not the same as it is with coronary artery disease, with stroke causing problems. So we have to identify this PAD, because when we have a PAD, we possibly have other systems in the body or other areas in the body which already have a narrowing. As one system has narrowing, the other systems also have buildup of plaque and narrowings. So we can have issues of heart attack, a stroke, and on top of that we already have a peripheral arterial disease. Next is, so we have to improve the screening programs. We have in our hospital system we have fairs wherein we bring community members and we make them aware about what is peripheral arterial disease and how do we diagnose them with a non-invasive methods like do an ankle brachial index like you saw the picture, and they get to know that, oh, I have peripheral arterial disease, and then they get back to their doctors and get on the treatment program, get on exercise program, and then try to get rid of smoking habit. So the next is the access to treatment. We have to improve that. So there are guideline based therapies regardless of gender or location which has to be implemented nationally. So that will bring this complications from this disease drastically down. And last but not the least is we have to improve or continue with the research into the peripheral arterial disease and identify genetic markers, and that will help us better understand the disease and how to prevent this disease. Thank you. If there are any questions, I'll be happy to take them.
Thank you. There are a few questions. The first question is, will my primary care doctor screen for PAD?
They, if you tell them, they normally, unless you identify a problem, doc, I'm walking and I get pain, I get a Charlie horse, then that will direct them to a peripheral arterial disease screening and they will feel the pulses. Otherwise, they might say, hey, there are so many other causes of pain in the calf, and they might direct you to a neurologist. But if there is, as I said, that there we have to be bringing awareness into the healthcare community as well. So yes, eventually they should. There's more awareness in the primary care level, and eventually they should be able to feel your pulses as a routine general physical examination.
Okay, thank you. Our next question is, what causes plaque buildup that cause PAD?
Plaque buildup is, we are humans. We will have human things with us. We grow in years. With that, there is deposition of cholesterol, and you'll be surprised that cholesterol deposition happens in the second decade of life. So on top of that, it's like a freeway. We have, and let 18-wheelers go over it repeatedly all the time without any brake, without any reconstruction of those vessels. And what's going to happen to them? The road will break down. Same thing, we are feeding it with cholesterol, we are increasing in years. On top of that, we are invincible, we smoke, we do drugs, we drink, and we have high blood pressure. We are careless about that. We don't take care of our diabetes, and then we expect that bad things will not happen to us. So we have to be aware that yes, if we are cognizant of all these things, bad things will not happen to us, and we bring awareness amongst us, community, home, healthcare, at all levels, and that will get some major awareness, and people will be benefited by screening programs and taking interventions at an earlier stage rather than a late stage where they lose toes, fingers, extremities, and in amputations, and that we don't want to see.
Okay, thank you. This does conclude our program, and thank you, Dr. Safaya, for this insightful presentation. Thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.
Thank you.